Hi, everybody. Happy New Year. Happy holiday season. Um, do you hear me now, Mike?
Yes, you're good.
Good. Happy holidays. Happy New Year. Welcome to Taylor Tuesday. We're starting the year off with a bang. I have to tell you that, in all honesty, although I don't see her very often, our guest speaker tonight is one of my favorite people in podiatry. And I've known her since she was a student, but more of that later. If you hear any background noise, I'm calling from a layover in Minneapolis, Minnesota, on my way back home to Whitefish, Montana, to help host a very dear friend's wedding. But nothing stops Taylor Tuesday from going on. Mike and I have been doing this for almost 2 years now. Um, we joked around. I think we called it doing something for the profession at one point. Then we called it a labor of love. Now it's probably going into labor. But anyway, it's been something that's been fun the whole time. So I'm sure all of you know my sidekick, Dr. Mike King, past APMA president, medical director, chief medical officer of Upperline Healthcare. Mike, I'm going to let you turn it over to you a little bit, and then before I get a chance to introduce Allie.
Super, super. Hey, everybody. Welcome. Happy New Year. As you can tell, our good friend Ira is a glutton for punishment. He's going to layover in Minnesota where it's 10 below zero, going back to Montana where it's 5 below zero. But anyway, good to see you again, Ira. Allie, always good to see you. As Ira noted, we've known Dr. Dewaters since she was a student. So it's really exciting for the dinosaurs here to welcome the new young bucks in who are taking charge now. So just a reminder for those of you who hear this a lot, we're happy you're here. We want to remind you that you can go back and review all of the webinars on the website, taylormedical.com. There's, as you know, they're always jam-packed with information, and I love going back and picking up little tidbits of things. I'm especially interested in this one tonight because I'm a novice when it comes to Epad. I think Ira, when I did a couple of cases when I was in Atlanta, you came down and did them for me to help me show me how to take care of it. But it's a very cool technology. A lot of clinics in our company have that now, and they swear by it. But go back. You're going to want to take a look at this again, and you can do that on taylormedical.com. The most important thing for helping this GPO, group purchasing organization, continue to thrive and to grow and to get better prices is for all of you to participate. And if there was one weakness, I would say we have it all. It's getting us all involved to participate. So take advantage of the savings that you're going to get. I think you might find that it's easier to get some products. There's a great supply chain problem, and everybody's suffering from it now. But if there's a way to find something, I know that Ira and his team are able to help us find that. So if it's out there, we can find it. But the only way to do that is to put all of your details together of the products that you have, the SKUs if you have them, the quantities, the sizes, where you buy them from, what you're paying for them. Put them on a spreadsheet if you're Excel wise, which, again, this dinosaur is not too good on Excel. Put it in a Word document, whatever you want to do. Make a pile of receipts. We'll figure it out. Get that over to Carla and the team, Ashley and Siobhan, and they can take care of this and get you just the absolute best prices. And maybe even find some of that stuff that other people aren't finding in the supply chain. I know Dr. Krause has amazing access to gloves right now if you're having any shortages on that stuff. So anyway, Allison, it's great to have you. Great to see you again. And Ira, back to you.
Thanks, Mike. And again, I really appreciate it. And Mike hit the nail on the head. Your Taylor Medical is here to help you, and we are able to try and solve all of your problems. So I think my mission is every time I tell people they're going to buy something, just check with our team to see if we can help you. And I'd like to talk a little bit about Dr. Allison Dewaters. I've known Allie since she was a student. She's in an orthopedic group. She's a New Jersey girl who stayed home, went to school at Temple, graduated and did a 4-year residency in reconstructive foot and ankle at the University of Pennsylvania. She's got a special skill set in reconstructive surgery, particularly in the forefoot area. She's trained in all the latest technologies. She continues to teach foot and ankle surgery to podiatric medical students and residents, and has clinics and private practices. She's a member of the American Podiatric Medical Association, New Jersey Podiatric Medical Association, and a fellow of the Foot and Ankle Surgeons. She's authored a chapter in the Montgomery textbook, and she was voted one of the best podiatrists by the Asbury Park Press. In her leisure time, she enjoys spending time with her husband and children at various sporting events. With that, I'm going to turn it over to Allie, and I'm going to disappear off of the screen and let her tell us a little bit about what's going on.
Great, thank you. So basically what I'm going to be going through is Shockwave, which I'm sure a lot of people are familiar with, and kind of go through what the science behind it is, and as far as treatment options besides just the traditional plantar fasciitis. I do use this in my practice. Again, I am with an orthopedic group, so we do see a large number of sports medicine injuries, and do get a lot of athletes. I do like to focus on this, as you know, my son is a big hockey player, baseball, lacrosse. My daughter is a swimmer, so I do get a lot of adolescent athletes as well. So I like to have other treatment options besides the traditional.
Hey, bud, I'm on a webinar for Taylor, my Taylor Tuesday, but I wanted to just, I'm not speaking.
Hey, Ira, just FYI, you're not on mute.
But I just wanted to hope that you got some information that we can probably get, that we have some stuff that can help him based on his list of needs.
So basically what I'm going to go through is the original science behind it.
Okay,
this
so
is
we'll have, I think the call for him is scheduled at.
I'm going to try to.
I'm going to send him a text. I'll send him a text, Allison. Keep rolling.
It is scheduled for.
Okay, thank you. So originally, Shockwave Technology is basically based on lithotripsy, which was developed in the 80s. And there was the whole design is to send in these pressurized sound waves to break up tissue and then increase blood flow to the area. Back in then the later 80s, it started with the extracorporeal Shockwave Therapy, and these were your big traditional units that again, send in this radial pressure wave to break up tissue and increase vascularization in the area. So I'm going to kind of come along, and this is just like as we look at the old Morris looking telephone. We have the same as far as the huge units that used to be available. These were the ones that were $2,000 out of pocket for the patient. They required anesthesia. It felt like your foot was being hit in the bottom of the baseball bat because it was so painful. And how we've progressed, you see the new units that we use, and this is the D-actor unit, which I currently use, and it's scaled down into a much more cost-effective, portable treatment option available for patients and practice. So biological effects, what we see with Epad therapy, extracorporeal treatment, and this is extracorporeal radial energy that's being transmitted into the cells. It's going to reduce or eliminate pain. You do get an analgesic effect with this, and that's where patients, as they're getting the treatment, they will get that kind of initial complete elimination of pain. So when they're walking, they don't feel that discomfort that they were having. We're increasing circulation to the area and neovascularization, as well as increasing cellular metabolism to break up and get rid of all of that inflammatory tissue. By doing this, we create this controlled inflammatory response, which then stimulates the neovascularization, tissue growth, bone growth. You get a release of neurotransmitters, so you're blocking those nociceptors that are giving that chronic pain. There's no induction of any other type of incision or things like that, so you don't have to worry about any type of bacterial. You'll see growth factors. You can break up calcium deposits, and it stimulates stem cell mobility. With that, sometimes I will incorporate this with a PRP injection, especially in some of the higher level athletes. I will do a Epad therapy, do a PRP injection, and then do Epad therapy again, so that way it stimulates those stem cells to get working there. So one of the things that we see is by sending in this pressurized sound wave, it will then create this disruption of these cellular membranes. And then by doing that, it's then going to create this whole cascade of growth factors. We'll see endothelial growth factors as well as vascular growth factors, all increasing blood flow to the area. And I'll describe this to my patients is I like to always kind of give them scenarios of how I break things down. And one of the biggest things that I'll relate to them and say, so picture your regular cells as like the size of a dime. And then picture your inflamed cells as like the size of a quarter. Well, the cell wall has a very tight membrane and it can only go so far. So when you send in a sound wave, in the cells that are normal and healthy that you're sending the sound wave, it's going to make them swell to like the size of a nickel. In the cells that are damaged and inflamed, when they're the size of a quarter already, they only go so far. So when you send in that sound wave, it actually makes them dilate and burst. So it's breaking up those inflamed cells and then increasing your body's blood flow to the area and creating this whole vascularization cascade.
Hey, Allison, I hate to interrupt you, but you're breaking up a lot. Maybe you can just click mute on and off and just see if that helps a little bit.
Sure.
That was much better right there.
Okay. So one of the studies that we looked at, this was in a rabbit that they were able to send in and look at an Achilles tendon. And basically, when you see the control study and one that was not treated with Shockwave versus one that was in a inflamed Achilles, you can see the growth factors that were present after the treatment. You see the angiogenesis, you see the endothelial growth factors, the vascular growth factors, and all compared to the control is significant. So again, microscopically, we see initially at week 0, you see a slight increase. Then again, at 1 week, you see a slight increase. And then at 4 weeks, you see a significant increase. Then you kind of see it drop down a little bit and then increase again at that 12 week. So I'll tell patients, generally after the first week of treatment, what you're going to notice is that your pain level after the initial treatment will be very good. Then it'll kind of creep back a little bit. After it creeps back, we do the additional treatment. You'll feel better for a little bit longer. We'll do the third treatment. Maximum results are going to be seen up to 12 weeks after the initial treatment. Generally around, that 4 to 6 week mark after that initial treatment, you really see that kind of peak performance as far as how the patients feel. They're basically feeling less pain less often, till they're back to doing their normal everyday activity, and they're like, my heel didn't hurt, or I noticed my Achilles wasn't bothering me. My range of motion was really improved. I was able to go on that run, and I didn't have to stop. So, sorry, skip that there. So basically, again, it's creating this self-renewal. We're all doing these things that are increasing our own growth factors, so our body is healing ourselves. And we know that with our traditional fasciitis and Achilles tendonitis, most patients are not coming in for 60 weeks after symptoms start. And at that point, they're starting to go into that fasciosis or tendinosis stage. So by doing this, it's creating that new injury to the area. So then we're increasing all of these growth factors and getting that body to, it recognizes that it's not just, oh, my heel hurts. Well, you should be better by now. So we're not doing anything more. We're not going to send any more blood flow to the area. We're not going to heal ourselves. But by creating this control trauma, breaking up that fibrotic tissue and scar tissue in the area, it will increase this whole vascular cascade again. So, and also when you have your Achilles tendons, this is more for the shoulder. I have guys in the office that'll use it for frozen shoulder, impingements, medial epicondylitis. But the Achilles, it does also help to break up some of the calcifications that are seen in that area as well. So here are the different types of heads that are available for the treatment options. And basically, I primarily use the focused radial head as well as the deep impact, and then I'll also use the deactivator depending on the conditions that I'm treating. The deep impact I'm going to be using more for my plantar fasciitis, especially if somebody has a really thick heel pad. The focused 15 I'm going to be using more for like my Achilles, and then the deactivator over in this area here, I will be using more for like the peripheral neuropathy, which I'll be talking about later, or some myofascial releases and things like that. It all depends on the depth that you're trying to treat, and also the patient themselves. The V activator handpiece. This is actually one of my favorite pieces. It is an extra piece that's available, but especially for plantar fasciitis and Achilles tendonitis, I love to use it for the calf. What I find is that it really helps to loosen up the gastroc muscle. It starts to increase that fluid to the area by doing that. It'll help to increase some lymphatic drainage. So that way, as you're breaking up that tissue, it's also then going to allow that to kind of filter out. It'll allow that little extra stretch in the fascial area and muscle fibers, especially for the gastroc and the soleus. And it generally just feels very good. The only thing that I will tell you is that when using this, especially when you're moving the machine, make sure that you do put a grip on this as you're moving it, because it, the way it sits in the machine, you want to make sure that you have a handle on it so it doesn't fall. So why acoustic pressure waves? Overall, what we're going to be looking at is we want to treat the underlying cause. We want to increase blood flow. We want to increase stretch. We want to break up scar tissue, improve mobilization of the tissue, and first and foremost, create no harm. So by doing this, we're offering patients a conservative treatment that is only going to help. There is no downfall to this. And when you look at, cost effectiveness, right now, you look at copays for patients, a lot of copays are going up to $50. So if you talk about a physical therapy, and if you're going 3 times a week, you're looking at $150 a week times 4 weeks, as opposed to $200 once a week with patients doing their own physical therapy, not taking anti-inflammatories. These are all things that are more beneficial to the patient and can be much more cost effective. And it's something that for us, we're not waiting on getting reimbursed from either therapy, from an office visit. It's a cash pay for the patient. Now, with that being said, I have had workman's comp patients, both Achilles tendonitis, plantar fasciitis. I've had some perineal tendonitis, and workman's comp has approved and paid for this for those patients. Skip ahead. So benefits, that's for easier healing. So patients undergoing surgery, basically, you have to wait for them to heal from their surgery itself, and then the physical therapy after. There's non-invasive, there's no incision. So again, you have that no downtime for the patients. You can treat both sides. Not often, if somebody has bilateral Achilles tendonitis, you're not doing bilateral Achilles tendonitis surgery. It's something that can be used by other patients that are in, other physicians that are in the office, as well as therapists that are in the office. Again, we talked about affordability. The way that I offer it to my patients is we do 3 treatments at $200 a treatment, or a package of $600 total for one side, $900 for bilateral. And I evaluate patients after and say, if you need an additional treatment, I do include it in part of my treatment package. Overall, 95% patient satisfaction. This is not just my results, but it's been several studies that have been done. Patients respond very well with conservative treatment, and they're happy that they come in, they're being treated 5 to 10 minutes, and then they're back to doing their normal everyday activity. They don't have to take time off from the gym, especially athletes. They really appreciate the fact that they're not having to stop playing their sport or doing what they need to do. So the Deactivator 100, this is the machine that I have in my office. We have it on this stand, and then if you notice the handpiece over to the side is the Deactivator. This is, again, what I recommend just kind of when you're wheeling this or wintering, make sure you hold that. The handpiece itself is very lightweight, and all of the controls are on the handpiece, so you're not having to fumble, which makes it very easy to kind of hold like pencil grip and adjust the settings as you're using this. You can offer this on. I do generally, depending on the patient. If I have a older patient that I don't feel may do as well with more of these response treatments like stem cells, PRP, I will offer a cortisone shot first. If I have a higher end athlete, I don't want to put in cortisone to them. I'm going to offer this as my first line of treatment. Long term, it's going to promote less scar tissue, less risk of infection, and get them back to doing their activities on a much quicker basis. So, we've seen that the acoustic pressure waves is going to improve that angiogenesis, promote that vascular response. Basically, it's going to also help block that pain in that initial. Again, I let them know right after, they're going to feel fabulous. As soon as I'm done with the first treatment, they feel great. They feel like they want to go out and they want to go run. They want to go do whatever activity that was really inhibiting them. I let them know this is going to last for a few days, and then you're going to start to notice that this will kind of creep back a little bit. But then we're going to do our next treatment, and it's going to last longer. And then we're going to do our third treatment. It's going to be longer, and it's less pain, less often. Again, there's no change in their biomechanics, so they're able to kind of continue their activity. I do still treat them with stretching, with orthotic devices. And you also get a really good feedback with the patient. So you start to know the area where it's hurting. So they don't need local anesthetic when you're doing this, because as you're doing this, you want them to let you know where the pain is. Because where there's no pain when you're treating it, you're not actually doing anything. You need to have that feedback system with them. So when you look at outcomes, there's a plethora of studies, all show over 80% success rate. The majority of them are closer to that 92%. Long-term pain relief, again, because we're treating the root cause, we're treating the chronic inflammation. And again, it's not just this, but it's in conjunction with doing your orthotic devices, doing their whole stretching exercises, changing foot gear. Again, it's cost effective for the patients when you look at the cost of PT, being out of work, downtime of surgery, cost of deductibles at this point. I know the majority of patients are coming in, they're having, that $2,500 to $5,000 deductible. And that's between your surgery, the anesthesiologist, the hospital, and as opposed to $600 with no downtime, and they're back to work the same day. So again, it's very, very simple to use. The handpiece is very lightweight. I love that the controls are in the handpiece. Some of the older units, had the dial that you would have to turn on to the machine. There's no scarring. If anything, this is breaking up scar tissue. You can have people that actually do treatment for you. We do have physical therapy in our office, and some of the therapists will offer this. I try to do this myself. I feel like it, especially for the patient, when they're paying for things out of pocket, they do appreciate it more when you're actually doing the treatments. You don't require any anesthesia. I highly discourage blocking it because, again, you want that feedback from the patient on the areas that hurt. And as you're treating them, sometimes you start to notice areas that really, they didn't really have pain are starting to develop a little bit more pain. And that's because you treated the original pain that they were getting. This is very, very simple to use. So the healing technology, again, it's when we wind up with these fasciosis or tendinosis, we have those nociceptor cells that are still firing and saying, like, hey, I still have pain, but your body's saying at this point, you should be better. We're not sending any more inflammatory cells, and that's why the anti-inflammatories don't work, and that's why the cortisone shots don't work. I'm very selective with this, and if somebody's had pain going on for 6-7 months, I'll let them know. I don't think a cortisone shot's going to work. If they do want to try it, I'll let them know. Then you're going to be required to wait 6 weeks for your start of the Epad therapy or start of a PRP or something like that. So I do encourage that if it is more in that fasciosis or tendinosis to kind of go into this. And a lot of patients too, when they're afraid of going on these anti-inflammatories with that black box warning. And you do get these vascular results. You see that in recruitment of the stem cells. You start to see that the inflammatory cells are filtering out and breaking up that scar tissue that's developed in that area. So these are overall success rates that you were seeing. 91% for shoulder pain. This is going to be for your Pacific shoulder. It's going to be for your frozen shoulder. 90% success rate for heel pain, foot and ankle international. 77% for that medial epicondylitis or tennis elbow. 76 success rate with the Achilles tendon. Achilles tendon, I do actually find this to be in that higher, 85% rate from my personal use, especially for when it's a more mid-substance. I find that when you have that retrocalcaneal insertional, it's a little bit more painful for patients, but then this is also more difficult surgically to treat, I find as well. Hamstrings, loosen up calf muscles, hamstrings, all that whole posterior muscle group. And that's where that V activator device I really find comes into handy because it really loosens up that posterior muscle group with that. So the biggest key that I find is patient selection, setting the expectations and letting the patient know the treatment protocol. Again, I do the 3 treatments and I'll have them back once a week for the first 3 weeks, and then I'll see them back 3 to 4 weeks later. If they are 50% better, then I will do an additional treatment at that time, and I let them know it's part of their initial. And because I'm doing an evaluation and management, I do generally fill out an office visit for that treatment, where for the other ones I am not. I am just doing the treatment because that's what the patient is coming in for. When they come in for that 4-week follow-up, it is I do a true evaluation of management and make sure we hit our ROS and everything else. I will then do another visit 3 to 4 weeks later. And again, if they need that additional treatment, I will include that in that. I let patients know it could be a maximum of 12 weeks. Generally, it's 4 to 6 weeks that we start seeing it, but however, it could take up to 12 for them to be completely better. I do find that the more athletic, the more active somebody is, they tend to do much better. Again, this is also depends on the patient and how well they're doing their other components as far as foot gear. whether or not they're doing their home stretching exercises, and whether or not they're following, the treatment protocol as far as anti-inflammatories and things like that. So Tony Iglio, he had a study where he looked at mass patients showing over 90% improvement, again, for plantar fasciitis. And again, the maximum results were seen at that 12th week. So acute patients versus chronic patients, again, the chronic patients are going to be the ones that it's been going on. Most patients we know are not coming in for 6 to 8 weeks after they've had plantar fasciitis, sometimes up to 6 months, because of that waxing, waning, and how that happens. You can do this in acute patients, and I've done this in some acute injuries. Start to break up like hematoma formations, decrease some scar tissue formation, and there are absolutely conditions or where patients are not a great candidate, and they do have to go into that more of a surgical treatment option. But this is something that you can use post-op to try to help decrease scar tissue and increase blood flow to the area. So treatment protocol, I will do generally a minimum of 3,000, depending on how big of an area it is, sometimes up to 6,000 treatments. I will palpate the area ahead of time. Sometimes I'll have patients mark off the area. Always use a coupling gel in order to, it's necessary in order to transmit the sound wave. You need that ultrasound gel. I also give a good amount of counter pressure for my Achilles patients. I always have them in the prone position, so that way you can really focus on that area. Anywhere from 2.6 bar to up to 3.6 bar. I go up a little higher on the hertz. Generally, I'll do like 16 to 17 hertz, but I'll also sometimes go up to 5,000 pulses, depending on the treatment area. I'll do one treatment a week for 3 weeks. In my higher end athletes, in the one office I cover, we do a lot of NFL and MLB players, and in that case, I'll do the treatment one at least twice a week. Sometimes I'll have one of the other physicians do it up to 3 times a week, because they're going to have that cellular turnover in that recovery area that we don't see in our, like myself, more sedentary middle-aged housewife. So again, it's all going to be patient specific. And then after, the big thing is that patients can resume their normal activity. I don't, again, unless they're like that higher end athlete that we're going to be treating multiple times, I don't tell them to go right after we do the treatment to go walk Costco or the Reservoir or Sam's Club. I let them know, it's going to feel really good. Don't abuse it. Let this kind of work. I'll let them take Tylenol if they need to. Normally, I have them do nothing. No icing, no anti-inflammatories. And again, I have to follow up 3 to 4 weeks after that third treatment. So each patient is different. I do find that, again, the more active and the healthier the patients are, they do respond quicker. And again, that's all done based off of how they're going to respond with their growth factors and how they're going to respond after any type injury. You'll see patients that are healthy are going to respond better to even an ankle sprain versus somebody that is more sedentary. There are other comorbidities, how long it's been going on, what they're doing for work. These are all things that are going to contribute, and this is all part of the conversation that I have in as far as patients' expectations and how they expect to respond to the treatment. Again, that analgesic response can last anywhere from 24 to 72 hours. Sometimes you'll notice by treating the one area, they have that pinpoint, heel pain, where that's that kind of plantar medial heel, and then they start to get that kind of pain to the lateral aspects. And this is what we see normally too with our traditional plantar fasciitis. As we start treating the primary issue, sometimes we do have to kind of expand it, and that's where I will increase my pulses to kind of get those other areas that, as we really hit that major problem source, we start to see these secondary areas kind of bounce and kind become more problematic as the other area resolves. So the other big thing that we're starting to see is the nerve regeneration, and there's been several studies that have looked at sciatic nerve after a crush injury and increasing blood flow to the area, breaking up scar tissue. Also, after carpal tunnel release, doing this prophylactically, and tarsal tunnel. We've done tarsal tunnel surgeries where they do really well, and then all of a sudden they start to get kind of that scar tissue formation right at that abductor hiatus. So this really helps to kind of mobilize that and break up some of that scar tissue formation, which can give us that kind of mimicked pain that we were getting before. Also, moments where you start to see kind of as that they're do great initially, and then all of a sudden at that kind of like 6-month mark, they start to get kind of as that increased scar tissue formation, and then start to have some increased symptoms in the area. This significantly helps to break up that scar tissue, so you don't see that kind of like rebound pain after doing some of these nerve releases. Diabetic neuropathy. There's been several studies where it looked at in decreasing the inflammatory response in patients that are diabetic. And by doing this, it is stopping some of the peripheral neuropathy from developing. Now, a lot of the studies that we have in humans have been looked at more treating it with VAS studies. Some of the inflammatory response studies that have been more in mice, where you're looking at actually inducing diabetes and treating them with shockwave. And the mice that were treated with the shockwave did not develop the same inflammatory response, which then also stopped them from developing peripheral neuropathy compared to the control group. VAS scores have significantly decreased in patients with peripheral neuropathy. And again, we think about the how this works, and we know that by decreasing inflammatory response and increasing blood flow to area is all going to help to improve pain and also break inflammation and filter out all the stuff that's going on. The other is diabetic wound care. Dr. Rogers has done some studies where he looks at Shockwave Therapy, and again, it's in all other factors being the same as far as HbA1c, offloading local wound care. By breaking up inflammatory cells and increasing blood flow to the area, it makes sense that it's going to help diabetic wounds to heal. He does have some preliminary data that looks at, saying that larger wounds may benefit from like higher doses. But again, it all makes sense. Let's get rid of the crap that's sitting around the wound, and let's increase the blood flow so we increase on the healing to the area. So these are all, several of the studies that basically look at heel pain, tons for heel pain. There's a ton for Fasciitis. There's a lot for Achilles tendonitis. The neuropathy studies are all now forthcoming. There's a lot of data coming out of several different studies that are out there looking at all treating diabetic neuropathy, as well as just chronic pain by filtering out chronic inflammation and increasing blood flow to the area.
Allie, can you hear me?
I can hear you.
So just so you know, we definitely had a little bit of a sound problem, but I will tell you the good news is everybody stayed on and listened. So even though they were hearing infrequent words, there were definitely some issues. Hopefully the recording will come out a little bit better. But I loved your presentation, by the way. Mike, are you there?
Yep, I'm here.
Okay. So Allie, I've got quite a few questions. Actually, I have one that talks about, you stated that your patients go back to exercise right away versus rest. Do you have a post-operative protocol that you follow?
So post-operative protocol, what I recommend is that patients can resume their normal everyday activity. As far as exercise, I don't let them do it the first day after, as far as like if they're, I won't tell them to go out and run today, let everything kind of settle in. But I will let them go the next day. And again, I stress the importance of them doing their home stretching exercises, making sure that they're continuing with proper foot gear, using the orthotic devices. And then tell them no anti-inflammatories, using Tylenol is okay, and no icing the area.
Okay, great.
Yeah, you answered one of my questions I had was your typical, are you still using the typical types of modalities such as equinus devices, orthotics, et cetera, et cetera?
Absolutely.
Okay.
So, Allison, I know this is, and I have my own issues, but how do you introduce the technology or this paradigm of care to patients? I obviously have not practiced clinically in a while, but one of the issues that I had was the first question patients would ask me was, is this covered by insurance? And then when I said it wasn't, but I feel that this is more effective, many had the response was, I'd rather just use what the insurance covers. How do you try and convince them that this actually is a better opportunity for them to heal better with even though it's a non-covered service? Am I making sense when I ask you that question?
Yes, definitely. So the biggest thing is that, and I mentioned it earlier, I don't know if people heard it with the audio breaking up, I apologize for that, is if you think about if we're sending a patient to physical therapy and they have a $50 copay for their physical therapy, they're going 3 times a week. You're looking at they're spending $150 a week for physical therapy for the 3 weeks. You also have co-insurance, deductible. So these are all things that it's not, even though it may be something that's covered by the insurance, their out of pocket may still be the same as what it's costing for the treatment. I also let them know that, it's going to get them back to doing their normal everyday activity quicker. I do have a fair amount of workman's compensation patients, and this is something that's covered for them. I also let them know, I said, well, if workman's comp is covering this for patients, it's because they know it works and it's going to get you back to doing your normal everyday activity quicker, as opposed to going through a surgical procedure and having downtime. You're going to be able to get back to doing what you need to in a much quicker fashion without having to take time off of work as well.
It makes complete sense, and I agree with you regarding that type of discussion, as that was a discussion that I had multiple times. My God, Allison, we're just seeing an influx of questions. Mike, I'll just take the next one, and then you can follow after me.
Sure.
This is actually from one of my classmates. I won't tell his name, but I love him very much. For plantar fasciitis, Allie, are there studies showing Epad superior to radial shockwave therapy?
Epad is radial shockwave therapy.
Well, that answers that question.
So, Allie, what are the contraindications to using Epad?
The only contraindications are going to be any type of malignancy, because again, we don't want to increase blood flow to the area in a malignancy. And I don't use it in any pregnant women.
Okay. Oftentimes also I speak for the nerve surgeons on coding, et cetera. So I found fascinating the neuropathy side of this. Are you treating it at the areas of discomfort, or are you going to a source? I mean, are you actually going to the level of like the sciatic nerve or the femoral nerve or whatever? So
I am treating it at a more local level. I'm kind of working on like the tibial nerve and kind of that distribution into the whole bottom of the foot. Sometimes I will do a little bit more like in the calf, like where the perineal is coming over, but primarily I'm focusing on like the tibial nerve distribution.
Thank you.
Ali, following up with the neuropathy, I know that you indicated that you are treating the Epad with neuropathy. And again, I see this question, and it might have been in your presentation but broken up. But what is your protocol for treating your neuropathy with Epad, and how would you rate your level of success?
So the way that I treat it is I use the D-actor, the fatter rounder probe on that, and I will use it again in that kind of tibial nerve distribution, kind of making sure that I hit that medial and plantar nerve. I will do around 3,000 to 4,000 pulses on each foot and once a week. I also do still augment this with treating them with making sure that they have good glycemic control. I am also focusing, I recommend vitamins between like the alpha lipoic acid as far as, either fulvic or Metnex, making sure that we're contributing that as well. So that way they have those tools that can also help to increase that kind of stimulation and help those nerves to regenerate themselves. But stress the importance of also that tight glycemic control.
Okay. Allison, is this something that you're comfortable training any ancillary providers in your clinic, whether it be rotating preceptors, medical assistants, RNs, or is this something that you in particular and is required as a physician to provide this care?
So this is something that I do have, again, we have physical therapists that are in our office that do it. I don't have the medical assistants do it. There's a couple different reasons. For one is that, when you provide a treatment to a patient and it's going to work and they're going to do really well, you kind of also want to have them respect you and have that kind of like feedback, like, oh, Dr. DeWaters did this, or Dr. King treated me with this and it really worked, not his medical assistant treated me and, it worked. So the therapist will, do it in our office. We have a whole separate therapy, but I try to keep it where I'm doing it. So that way, I kind of have that success for myself with those patients. And I think it promotes more for your name in the community by having you perform those services.
So question following up on the neuropathy neuritis, do you have any particular protocol for Baxter's neuritis?
So there have been a couple studies. I know Dr. Barrett actually had done one that he really looked at treating Baxter's neuritis. I kind of just follow the same kind of protocol where depending on the patient, I'll use either the deep impact or the focal 15 and kind of hit the same, target range as far as, what the patient will tolerate between the 2.6 to 3.6 bar and up to 3,000 pulses. I'll do the same thing a week apart for the next 3 weeks. But again, kind of work as, I also am big on having patients do like some massage at home as well to try to help, kind of break up some scar tissue too.
Ali, I know you've discussed multiple different treatment protocols, and I'm just wondering, because depending on the severity of the condition, the length of the condition, the etiology, the location, you may vary the frequency of shockwaves that you've administered. Does Medical Wave have any type of printed material or recommended, not telling people how to do it, but recommended levels of frequency of shockwaves for the state of the condition? Does that make sense?
They do. They absolutely have kind of treatment parameters that they recommend for a variety of different conditions. And again, a lot of it though, too, you have to go based on the patient feedback. I've had patients where, I've gotten up to 5 bar and they're not even flinching. And then I've had some where it's like 1.2 and they're jumping off the table. So you really have to kind of go also based on how the patient's responding and how they feel.
What would you say? What do you think the learning curve of that is, Ali? Obviously you're a master at this now, and part of it is volume and use. And so if someone is going to invest in a unit, get this rolling, and What do you think there? What's your estimate of a learning curve for some picking up a service like this and doing it well?
I don't think there's much of a learning curve with it. It's more kind of just like going slow. And, as you start treating the patient, you'll kind of see it like titrate up to their pain level. And it's a lot of patient feedback too. And it's having that communication with the patient to let them know, like, listen, I need you to communicate with me as far as how you're responding to this treatment. Because if I, hit you with 5,000 pulses in this area and it doesn't even make you flinch, well, then you're not going to have a success to it. We need to make sure that we're hitting the right area. And as long as, you're having that conversation with the patient, and you it's the only downfall with doing like an Achilles prone too, is that you don't see that kind of like facial expression where you're doing the plantar fascia or like a peroneal tendon, where they kind of like give you that, you hit the right spot. And be like, no, I know it hurts, but that means we're in the right spot, and that means it's going to work. And promoting that positivity when you're having that conversation with them.
Allie, when I was using this technology in the practice, and particularly for plantar fasciitis, I actually found that it was beneficial to actually treat the distal insertion of the Achilles tendon just because they were fibers that connected with the plantar fascia. Do you find that is something that you do when you're treating your plantar fasciitis patients as well?
Sometimes I definitely do. And that's where, I also do that V activator for the gastroc to really make sure that we loosen up that muscle. It's a huge component with making sure that you're stopping that pull in the back part. And you do have that patients where, the pain kind of radiates up into that back of the heel. And absolutely, I will do that same where you kind of hit that distal insertion area.
I have another question that has popped up. Sometimes patients have a condition that is just so critically painful that we would have them immobilized prior to even starting Shockwave Therapy. I know you talked about, doing your normal modalities with stretching and maybe even like an Aquinas brace or, orthotics. Do you ever find that when you're putting them in a treatment protocol for, plantar fasciitis or Achilles tendonitis, that in conjunction with your Shockwave Therapy, you do need to immobilize them to help with the healing process?
I tend to not do it for my plantar fasciitis. I will do it for the Achilles tendonitis. For the plantar fascia, if they're that painful, then sometimes I'll boot them before, but at that point I'm getting the MRI to make sure they don't have a stress fracture before, we're treating anything. And if it's showing that severe, then I'll immobilize them for, a few weeks to get everything to calm down before I even touch them with the Epad, just because they're not going to tolerate it if they're that painful.
That makes sense.
Good.
I have one last question here, Mike, if I think I'm going to go through it. Allie, I know you mentioned some of it, and again, from the clarity, I might not have heard it all. Do you use the Epad in conjunction with any type of either PRP or injectable amniotics or any other treatment plan, or do you mostly do this as an isolated treatment?
No. So yes, I again apologize for the audio quality. But yes, that is something that I do, where I will do it in conjunction with the PRP. With the PRP, what I will do is treat the area ahead of time to kind of increase that blood flow, do the PRP treatment, and then also do an additional treatment after, so that way it mobilizes those stem cells. And then again, if I am doing a PRP injection, then I am immobilizing those patients for those 2 weeks. And I will do the same thing though, treatment once a week for those, for the 3 weeks in conjunction with it.
That's all I got here, Mike. You got anything else?
No, that's all the questions. She hit most of them in the talk, which was great.
Well,
the rest at the end.
The only questions that I really didn't address were the insurance related questions. I can tell you all that Mike and I have been probably fighting this for years and years and years. I remember when Epad came out and there was some coverage. I think this is one of those medical treatments that, sometimes less is more. And I think that this is a modality that works really, really well. And I'm afraid that if it did get insurance coverage, might not even cover the cost of your device. So I know that doesn't sound great. I know Ali mentioned that it's covered on workman's comp. So that's something good to think about. At least the employers want to get their employees back to work faster. But I don't really know of any aggressive insurance push that's being made at this point. Are you aware of anything, Mike?
No, and being distant from APMA at this time, I haven't really heard anything, but we haven't really talked about it. I mean, we looked at that 15, 18 years, 17 years ago and kind of got nowhere, and it's been squashed every time, mostly, believe it or not, Ali, by your colleagues in orthopedics.
Yeah.
But, the whole point is, like Ira mentioned, sometimes be careful what you ask for because you end up getting a dime for a dollar service. So,
well, I want to thank everybody for joining us. We again apologize for the sound difficulties, and I appreciate everybody that stayed on. I mean, very few people left. They were really engaged as the best as possible. It's been amazing during the Q&A. Ali sounded perfect, and you would have never known there was a problem. And we just appreciate everybody coming out for our first Taylor Tuesday. We are excited next week to have a presentation on another modality that is used in clinics called the REMI. It is a class 4 laser. Many people are using it for muscle stimulation and for nail care, for laser nails. So it should be a very, very good presentation. And I want to remind everybody that Taylor Medical is here not just to help your practice, but to help the profession. We've given $50,000 in student scholarships, and our goal is to continue to support the profession of podiatric medicine and surgery. So without further ado, Ali, it was an absolute pleasure having you on the phone.
Thank you very much.
And thank you for joining us. And Mike, thank you for taking time after a busy holiday season, and we'll see everybody in 2 weeks.
see you. Thanks, Ali. Good seeing you. Be well.
Happy New Year. Thank you.
Bye.